In terms of recommendations for physical activity, so according to the ADA, most adults with type 1 diabetes and type 2 diabetes should engage in at least 150 minutes or more of moderate to vigorous intensity aerobic activity per week. And this should be spread out over at least 3 days per week, with no more than 2 days in a row without activity. Shorter durations, up to 75 minutes per week of vigorous intensity or interval training, can be sufficient for younger patients and more physically fit individuals. All right. In terms of glycemic targets, so assessment of glycemic control is assessed by so there's a couple ways. So as we all know about the A1C, but now we have continuous glucose monitors, which I'm going to go through shortly. And we can look at how much are they in range, in target range on these CGMs. The glucose monitors also provide a metric called a GMI, which can be thought about semi-equivalent to an A1C that you get in a blood test. So these are the different ways that you can assess their glycemic control. So we recommend assessing glycemic status by an A1C or other glycemic measurements such as time in range or GMI at least 2 times a year in patients who are meeting treatment goals and have stable glycemic control. However, it should be at least quarterly in patients who are needing frequent therapy adjustments or are not meeting their glycemic goals. This is a picture of a CGM. And so this basically, when you look at a continuous glucose monitor like the Libre or Dexcom, you want to look for the AGP report. So that's known as the ambulatory glucose profile. In the diabetes world, is sort of like your equivalent of an EKG. So it really lays out the blueprint of what a patient is doing at home in terms of their blood sugars. Generally, when we look at a CGM, it's giving the past 2 weeks of data and is giving you the average of that in the AGP sort of graph that you see in the middle there. So that takes 2 weeks of data and sort of plots it out as if it was a full day from midnight to the 24 hour, basically showing you what their blood glucoses are doing in a 24-hour day. We'll go through the targets, but as you see in the middle, the AGP, the middle section in green is where their target range is. So that's anywhere, when you're looking at the graph, you want to see how much are they actually falling in that target range. And then, of course, you can see the lines that are going above and below in red, so hypoglycemia, and above that in orange. And the trends of the graph can let you know, are they going high after meals? Are they going low, fasting or overnight? So it can really give you more information as to where to target changes to their insulin or their diabetes regimen in general. So moving on to the next one, this is basically showing how you can read these reports. So first you want to look at the number of days of the CGM device worn. So we recommend at least 14 days. That truly gives you a good amount of information for understanding their A1C. And then you want to see how much in those 14 days they were actually using their CGM. How long was it active? Was it off of them 4 days because they lost their sensor or the sensor wasn't working? So we generally recommend trying to make sure the patient is using it at least 70% of time in those 14 days. The top of the CGM report also gives you their mean glucose value, and then it gives you an indicator called a GMI. So the GMI is basically taking the past 2 weeks of glucoses and spitting out essentially what you can consider an A1C. So it will predict what an A1C might look like, but just using the past 2 weeks of information from the report. You can then look at a parameter called glycemic variability. And so you want to target a variability less than or equal to 36%, because your A1C is really an average of your highs and lows. If patients are having a lot of glycemic variability, the A1C may not be representing exactly truly how well their diabetes is being controlled or being managed. Patients who have a lot of hypoglycemia, it can drive down their A1C. And so in theory, it could look like their diabetes is doing well when you get a blood test, but if you open up the report and see a lot of hypoglycemia and a lot of glycemic variability, that gives you a different story than just the blood test. So then it breaks it up into telling you what our target range is. So time in range is defined as time between 70 and 180, and that's really where you want your patients to sit. Time above range is defined as 181 to 250, or very high level 2 hyperglycemia is greater than 250. Hypoglycemia level 1 is defined as 54 to 69, and then below 54 is level 2 hypoglycemia. So here are actually your targets when you're looking at a CGM. If you're using their AGP or their GMI to assess how their diabetes is doing, basically you want to make sure they have a time in range of at least 70%. So that's the main thing that you look at on their initial report. When you're first looking at their numbers, you want to see how long are they actually in that target range, and you want to get that to above 70%. The other thing that's really important is to look at hypoglycemia, so time below range. You don't want a patient to be less than 70 more than 4% of the time. So really you're targeting to less than 4% of hypoglycemia. And for level 2 hypoglycemia, you want that to be less than 1%, because of course that can be very dangerous. Generally, when a patient comes in with a CGM, if we're seeing a lot of hypoglycemia, we actually target that first before we target the hyperglycemia, because it can be very dangerous. And so if you're seeing that they're, time below range more than 4%, you really want to address that first and figure out what's going on there. So that's for the general sort of healthy population. However, in patients who are more frail or have, increased risk of hypoglycemia, you can actually just target a range of 50% for time in range, with less than 1% time below range recommended. So really for that, we're really focusing on no hypoglycemia. In terms of A1C goal, generally we say 7%, but if you can maintain an A1C less than 7%, it can be acceptable and beneficial in patients who can get there safely without significant hypoglycemia or other adverse effects of treatment. And less stringent A1C goals, similar to the time in range of less than 8%, can be appropriate for patients who have limited life expectancy, or if you feel that the risk of hypoglycemia and the harms of treatment are greater than the benefits. So this is another table from the ADA guidelines that shows, again, those targets, A1C of less than 7%. And then when you're looking just at basically how do you interpret the actual glucose values, you want them to target a preprandial glucose value of anywhere from 80 to 130. And the peak postprandial capillary glucose should be less than 180. So this table is again talking about hypoglycemia. So we have 3 levels of hypoglycemia. Level 1 is anything less than 70, but greater than or equal to 54. Level 2 hypoglycemia is a glucose less than 54. And level 3 is basically a severe event characterized by altered mental status or physical status requiring assistance for treatment of hypoglycemia. So if someone else has to help them treat that hypoglycemia, irregardless of what their blood sugar is, it's considered level 3. So there's no cutoff for a level 3 blood sugar. In terms of treating hypoglycemia, this is the recommendations according to the ADA. We generally tell our patients to remember the rule of 15. So they want to check their blood sugar. If it's less than 70, they should treat with 15 grams of fast-acting carbohydrates, and then they should check their blood sugar 15 minutes later. So we let them know the rule of 15. It's just an easy way for them to remember 15 grams of fast-acting carbohydrates and check their blood sugar 15 minutes later. So patients who are at risk for level 2 or level 3 hypoglycemia should be prescribed glucagon. So really in all of our patients who are on insulin, we always make sure they have glucagon at home, because in case of an emergency, if they truly were to reach that level 3 hypoglycemia and they needed assistance from someone else, they should have an emergency glucagon at home. It comes in the form of a spray or an injection. And those around them should also know how to use it. So it's important that family members and caretakers know how to give them glucagon as well. So I wanted to touch base on diabetes technology. So they also talk about this in the ADA guidelines. So now that we have so many devices out there, so many continuous glucose monitor devices out there, it definitely gives us a lot more information on the report, as you saw. So there's a couple different kinds. You can have real-time continuous glucose monitoring. That's when the system measures and displays the glucose levels continuously. So Dexcom is considered a real-time continuous glucose monitor. You can have intermittent scanning continuous glucose monitors with and without alarms. And that basically means they have the CGM on all the time, but in order to actually, for the patient to see the blood sugar, they need to scan past it and see what the blood sugar is doing at that time. However, now actually even Libre was the one that was intermittent scanning, and the older Libres are still intermittent scanning, but the newest Libre that's out there, the Libre 3, is actually now more of the continuous glucose monitor. So it's essentially becoming similar to Dexcom. But the Libre 2 that most of our patients are still on is still the intermittent scanning. So a patient has to scan it, and they should be scanning it at least every 8 hours. Otherwise, it doesn't show up on the AGP report when you pull it up. You'll lose a lot of that data. So if you pull up an AGP report and you notice that there's just big gaps of data if they're on the Libre that requires them to scan, it's because they have not been scanning it properly every 8 hours. So you lose a lot of that data, unfortunately. In terms of pharmacologic approaches to glycemic treatment, so I think this is sort of the most important part of the ADA guidelines, which is talking about which medication to choose for type 2 diabetes. And so really now we take into account what their other comorbidities and risk factors are. So in patients who have cardiovascular disease, heart failure, or CKD, that can really help guide your treatment decision. And I'll show you those algorithms. All right. In terms of metformin, so if a patient is on metformin, it should be continued even on the initiation of insulin therapy. So I think this is really important because a lot of patients will say they were taken off of metformin once they started insulin, even if they were tolerating the metformin. Of course, if they have side effects or GI side effects and they cannot tolerate it, then it's okay to discontinue it. But it does have ongoing glycemic and metabolic benefits. So even if they have an extremely high A1C and you're starting them on insulin, that doesn't mean that they need to stop their metformin, that they're not getting any benefit from the metformin. In terms of insulin, when do you want to think about starting a patient on insulin versus some of the other medications? So it definitely should be considered if there's patients who have evidence of ongoing catabolism. So if they have weight loss because of their high blood sugars, then they should be put on insulin right away. If they have symptoms of hyperglycemia, so if they're complaining of increased urination and thirst and weight loss, those are all signs that they should be put on insulin. And when their A1C level is greater than 10% or their blood sugars are persistently in the 300s, again, you want to consider starting insulin in those patients. So this is a really good table from the ADA. So it's hard to read because there's so much information on here, but if you pull up the ADA guidelines and pull up this table, I think it's a good thing to keep in hand. It really goes through every medication, the class of medication, what the effect on weight is, what their cardiovascular benefits are, do they have renal benefits, are they approved for renal benefits, and when you consider them. And so I think this and the next table, which I'm going to show you, I think are sort of the two best algorithms to keep in front of you when you're trying to decide which medication to use. What are the side effects of each class of medication? So like I said, it's hard to read because there's a lot of information out there, but I think it's a really helpful table to keep in hand. So moving on, this is the algorithm that the ADA has published. So this is really how they want you to think about and how we should be thinking about prescribing diabetes medications. And so going back, it's kind of thinking about that patient-centered approach that we had talked about earlier. But in patients, we really want to choose medications that address their risk factors and address their other comorbidities, especially heart disease, heart failure, coronary artery disease, and CKD. So in patients who have a cardiovascular disease, you can choose either a GLP-1 receptor agonist with proven CVD benefit, or you can choose an SGLT2 inhibitor with proven CVD benefit. According to the algorithm, if their A1C is above target, if they're already on a GLP-1, then you can consider adding an SGLT2 and vice versa. So those are patients who have cardiovascular disease. So MI, stroke, revascularization procedures, all fall into that category. If they are high risk patients, so basically defined as patients 55 years or more, with 2 or more additional risk factors, including obesity, hypertension, smoking, hyperlipidemia, or albuminuria, again, you want to think about starting the GLP-1 or an SGLT2 with proven benefit. And then the table before this that I brought up, that actually lists out every medication, which one has been shown in the trials to have cardiovascular benefit and which ones have not been. So for example, if you go to the GLP-1s, dulaglutide, liraglutide, and semaglutide, so Ozempic, Trulicity, and Victoza, those are the ones that have been shown to have cardiovascular benefit. On MACE, when they looked at major adverse cardiovascular events in the trials, they have a neutral effect on heart failure. And then in terms of the SGLT2 inhibitors, again, it's sort of divided in between, have they been shown to have an effect on MACE? Have they been shown to have an effect on heart failure or on kidney disease? So I think the table before, this table really goes through all of that, and you can see exactly which medications would be good to use in those instances. Okay, so if a patient primarily has heart failure as their main problem, either reduced ejection fraction or preserved ejection fraction, then an SGLT2 inhibitor should be considered first in these patients. If a patient has CKD, so if their GFR is less than 60 or they have an elevated albumin in their urine test, then you should consider using, again, an SGLT2, preferably, that has been shown to help with CKD progression. And then on the other side of the table, basically is thinking more about weight loss and glycemic control. So it's just showing you which medications are the most efficacious for weight loss and which are the most efficacious for A1C control. And so really, when using this algorithm, it's not an either or approach, it's sort of looking at the whole picture and trying to see which one will help with their weight loss, which one will also target their cardiovascular disease, and which one will also help with their A1C. So that's how this is sort of laid out. In terms of cardiovascular and risk management, so outside of just the glycemic control, we also want to think about their blood pressure. So you want to treat hypertension if their blood pressure is persistently elevated, so greater than 130/80. Targets for blood pressure in our diabetic patients is less than 130/80 if it can be achieved safely. ACE inhibitors or ARBs at the max tolerated dose are indicated for blood pressure treatment. It's the first line of treatment if they have hypertension in people with diabetes and they have an elevated urinary albumin to creatinine ratio. So if they're high, if they're anywhere from 30 or higher, it's considered first line treatment to start with an ACE or an ARB to target basically both of those issues. And then if one class is not tolerated, the other should be substituted. In terms of lipids, so in adults not taking statins or other lipid lowering therapy, you should obtain a lipid profile at the time of diabetes diagnosis, at the initial medical evaluation, and every 5 years after if they're under the age of 40 or more frequently if indicated. You want to obtain a lipid profile at the initiation of statin therapy or other lipid lowering therapy, and then again 4 to 12 weeks after the initiation or change in a dose, and annually thereafter. So this is talking about your goals of lipids in terms for primary prevention. So in patients who are aged 40 to 75 years old without cardiovascular disease, um, just having diabetes in itself already qualifies them for using a moderate intensity statin therapy in addition to lifestyle therapy, even if they do not have any other risk factors. If they're 20 to 39 years old and they have additional cardiovascular risk factors, it could be reasonable to actually start a statin therapy in addition to lifestyle therapy. So you can consider it in these patients according to the guidelines. If they are 40 to 75 years old and they have high risk, or they're higher cardiovascular risk, including those with one or more cardiovascular risk factors, then you want to use a high intensity statin therapy to reduce their LDL cholesterol by 50% of baseline. And basically you want to target an LDL of less than 70. So this is for primary prevention. This is the just a reminder of which medications are high intensity and which are moderate intensity. So for people with diabetes from 40 to 75 years at higher risk, especially with multiple risk factors and an LDL of greater than 70. So if you already are treating them with a statin and their LDL is greater than 70 and they're sort of in that very high risk group, then it's reasonable to add a Zetia or a PCSK9 inhibitor to their maximum tolerated statin therapy. In terms of secondary prevention, so for people of all ages with diabetes and cardiovascular disease, high intensity statin therapy should be added to lifestyle therapy. Unlike primary prevention, where we were talking about thinking about a moderate one, if they have for people of all ages, this is for secondary prevention, then you go straight to a high intensity statin. So for people with diabetes and cardiovascular disease, again, for secondary prevention, treatment with high intensity statin is recommended to target an LDL of, again, reducing their cholesterol to greater than or equal to 50% from baseline. And really, you're actually targeting a LDL goal of 55. So we talked about 70 in primary prevention and really being more stringent in secondary prevention to try to get that LDL down to 55. And again, if you're not there with just a statin, then you can consider adding on additional therapy to that. In terms of CKD and diabetes, you want to get their urinary albumin ratio and a GFR at baseline, and people with type 1 diabetes. In people with type 1 diabetes with duration of greater than or equal to 5 years, and then in all people with type 2 diabetes. So as soon as someone is diagnosed with type 2 diabetes, you should be checking their urine test and their kidney test. But for type 1, they say it's okay to wait at least till they've had diabetes for 5 years, but at onset for people with type 2 diabetes. In patients who have established diabetic kidney disease, a urinary albumin and GFR should be monitored 1 to 4 times per year, and that really depends on the stage of the disease. So in non-pregnant people with diabetes and hypertension, either an ACE inhibitor or an ARB is recommended for those with moderately increased albuminuria. So they're saying anywhere from 30 to 299, and is strongly recommended for those with severely increased albuminuria, so greater than 300. And so this ties into also the blood pressure recommendations, where they say ACE and ARB should be considered first-line therapy for blood pressure in patients who also have increased albuminuria. This is another good chart from the ADA, and basically is just talking about their stage of CKD and their GFR and when you can treat it or when you should considering referral to a nephrologist. And then in terms of SGLT2 inhibitors, so I just sort of took a screenshot of the guidelines here because they basically have different levels of recommendation. So For people with type 2 diabetes and diabetic kidney disease, a use of a SGLT2 inhibitor is recommended to reduce CKD progression and cardiovascular events as long as their GFR is greater than or equal to 20 and their urine albumin is greater than or equal to 200. So if patients have type 2 diabetes and diabetic kidney disease, you should definitely consider starting them on an SGLT2 inhibitor. And that's a grade A recommendation, which is the strongest recommendation. And then the second one is a grade B recommendation. So that's really the only change. But basically it says if they have CKD and their albumin ranges, your urinary albumin ranges from normal to 200, then again, you should consider starting an SGLT2 inhibitor. And then the last one there says in people with type 2 diabetes and diabetic kidney disease, you should consider use of an SGLT2 inhibitor as long as their GFR is greater than or equal to 20, or a GLP-1 receptor agonist or a nonsteroidal MRA, additionally for CV risk reduction. So overall, I know it's a little confusing, but overall, basically, in patients who have CKD and type 2 diabetes, we should be considering adding on SGLT2 inhibitors in these patients. And that is all I have.
Awesome. Thank you so much, Dr. Kumar, with delivering such a great didactic. We really do appreciate your time. Does anybody have any comments or questions?
I'm curious whether the other primary care people around have been successful at getting some of the cholesterol medications paid for. I mean, we can get statins, but nobody but the cardiologist seems to be able to get some of the others paid for.
Does anybody relate to what Dr. Rexrow just mentioned or have any insight on this?
Interesting question.
Patients on Medicare copay is still about $300 a month.
Yeah.
Wow.
So we don't have many who go that route because they can't afford it.
No, that's really unfortunate. Thank you for providing that, Sarah. And then we had a question, how do you feel about cardiac patients using the SGLT2 and GLPS in non-diabetic patients? Any concerns with that?
Is that to me, Dr. Perini? So I think, yeah, now the SGLT2 inhibitors are being used a lot for just heart failure, and you don't necessarily have to have a diagnosis of diabetes. I think there's still a lot of ongoing debate between endocrinologists and cardiologists when it comes to this. We tend to be a little bit more cautious, I think, when we prescribe these and we look at what their A1C is and we look at sort of their risk factors for developing side effects from the SGLT2 inhibitors, like increased risk of euglycemic decay or urinary infections. And I think in cardiology, they're not necessarily looking at that. So I think those are some of the pitfalls, but I guess, sorry, you said in patients who don't have diabetes. I think overall then if they don't have diabetes, so we're not too worried about some of those risk factors that come from the hyperglycemia associated with them. They are safe to use because these medications should not cause hypoglycemia in patients just due to their mechanism. So I think overall it would be fine to use as well for their cardiac benefits or their renal benefits as well.
Thank you so much for the feedback and the question. Another that came in, does fructosamine have a place in DM monitoring? Sorry if I butchered that.
Yeah, we still do use fructosamine as well, basically in patients who, if if you feel like their A1C is not accurate for, it can be affected by a variety of things, anemia, iron loss. So that can affect their A1C levels. Then fructosamine can be used in place of an A1C. So especially if you're seeing patients who have elevated A1C, or if they've had like a recent blood infusion that will affect their A1C. If you feel like their blood sugars are off from their A1C, then that's when it sort of clicks in our mind to check a fructosamine as well.
Thank you. Go ahead, Fred.
Yes, ma'am. The reason I joined this is because I do have diabetes, and I was wondering, so I had some question like metformin. I've been on it for 10 years. And some of the studies I read that it's not good for my body to be on it that long.
Yeah, so I think there's a lot, unfortunately, of bad press out there for metformin. In general, it's a very safe medication, actually. It is renally excreted, so we do keep an eye on the kidneys in terms of reducing the dose if we need to based on the kidney function. But there's no harm of or long-term problems that have been found with being on metformin, even though there's a lot, like on the internet, and a lot of patients have the same question. They come in and ask, is it safe to be on this medication? And really, we still think the benefits of being on metformin outweigh any harm, and there hasn't really been shown to be any long-term harm of that medication. That being said, like I had mentioned in one of the points, that you should have your B12 monitored if you're on long-term metformin. It can decrease those levels, so that is something to keep in mind.
Okay, yeah, I'll talk to my doctor about the B12 because I don't believe I've been checked in probably 5-10 years. So Thank you, ma'am.
Absolutely.
Excellent. Thank you so much. And, to build upon that, can we take B12 just to try and like counteract those type of impacts, or should we check it first?
We usually recommend still checking it. We don't sort of like empirically start patients on B12 if they're on metformin.
Perfect. Thank you. And then I have another question that came in, and then we'll go into the case just for the interest of time. I love all the questions. Thank you so much. When there is a disparity between A1C and the CGM data, which do you trust more?
That's a great question. So we actually trust the CGM data more because the A1C, like I mentioned, can be affected by a lot of things. And also it's a 3-month, it's sort of showing their blood glucoses for the past 3 months, whereas the CGM is going to be the most up-to-date data in the past 2 weeks. So the A1C may not necessarily reflect what their current blood sugars are doing. And so the CGM data actually gives us a lot more information, I feel like, than an A1C.
Excellent. Thank you very much. Thank you for the questions. All right, Dr. Rexroad or Janet, are you guys ready?
I guess so. I guess I really need to thank Janet for getting all that together. It's my patient, but she's the one that got everything together to send to you guys. It's not a diabetes question, although the patient is diabetic.
Okay.
She's a 68-year-old woman, diabetes, hypertension, obesity, fatigue. She quit smoking like 6 years ago now, or 7 years ago, which is great. She has had slightly elevated calciums on her labs going back probably that same 7 years or so. But in March, suddenly her calcium jumped up to 14 on our labs. So of course we brought her back the next day and repeated it. And it was no longer critical, but it was still elevated. At the same time, her hemoglobin dropped by 2 grams from where it had been 6 months earlier. Her indices looked slightly microcytic, but not dramatically so. Her PTH was elevated, as you can see there. Her ionized calcium is also elevated. Her ferritin's below normal. Iron saturation, those sorts of things. Her hemoglobin A1C actually looked pretty good, but as we just pointed out, sometimes anemia monkeys with that result. Her renal functions have been essentially normal. Her hemoglobin has stayed about 10 for the last couple of months. And so we kicked it around among ourselves here and decided to send her to hematology because we thought that would be maybe more expedient and more urgent if there was something going on in her bone marrow,
Mhm.
rather than sending her straight to endocrinology for the hyperparathyroidism. So she went to hematology, and he kind of politely told us that, yeah, this is, she needs, workup for iron deficiency and endocrinology. So it's, around here, that appointment's going to take a few months. So we're kind of
Mhm.
looking for what we can do to help move along the workup or get her treated while we're waiting on that. Her physical
Mhm.
exam is essentially unremarkable except for BMI. I mean, the woman was a restaurant
Mhm.
cook for years. I mean, we've all eaten meals that she's prepared. So,
Mhm.
she's always been plump, probably always will be. Okay, yeah, stick there at the medication list, if you would, Elizabeth. You can see your medications. One thing Janet discovered yesterday is maybe we should stop the HCTZ. Um, so we're interested in recommendations from you guys.
Sure. Yeah, I think I would actually stop the HCTZ given the hypercalcemia because it could make that worse. And then I would repeat her levels, like her PTH. Did you get a vitamin D level?
Looking. Not recently. So that's something we could
Okay.
add, certainly.
Yeah, so I think you could like stop the HCTZ first and then just get sort of a repeat calcium, PTH, and vitamin D off of the medication. And then if it's still showing that same pattern, probably it will of the hypercalcemia with an elevated PTH. The next step is I would go ahead and get a 24-hour urine calcium in her. So basically just looking to see if she's spilling out a lot of calcium into the urine, because that can also help guide the decision of what to do next for this hyperparathyroidism. If the vitamin D is low, then I would first replete. That could also be driving up the PTH a little bit. Um, so it sort of depends what the next set of blood tests show. Um, but if the calcium is still high with a high PTH, then you want to definitely go down the route of the primary hyperparathyroidism, get a 24-hour urine calcium on her that can help the endocrinologist. And then in terms of getting imaging, a thyroid ultrasound and a nuclear sestamibi B scan of the parathyroids, those are usually our next steps.
Okay.
I don't know if Dr. Preeny or Dr. Barguthi have any thoughts on that too.
I was curious whether bone density comes into this.
Yes, we do. Sorry, how old was the patient
She's
again that you
68,
mentioned?
so she's postmenopausal.
Yeah. Yeah, so when we think of like indications for a surgery for primary hyperparathyroidism, we definitely look at their bone health. Has she had a bone density in the past?
Um, Not that I could see. She's one of those people that's been a little hard to get in sometimes for things we want to do.
Okay,
She had lumbar
okay,
spine x-rays done, but has not had the actual DEXA.
okay. Yeah, so things that we want to look at is definitely the bones. And you want to, when you order the bone density scan, you want to include the forearm because primary hyperparathyroidism can affect the cortical bone more than some of the other bones. So we take a look at the forearm. And then this will all sort of just help the endocrinologist decide, is it someone you can continue to monitor, or is it someone who would need to go for surgery for primary hyperparathyroidism? So we're looking at bone health. Does she have osteoporosis? Is she spilling a lot of calcium into her urine, which puts her at increased risk for kidney stones? Or if her calcium, even off of hydrochlorothiazide, is coming back one greater than normal, those are all indications for surgery. Or if she's symptomatic from this calcium, that could be it. That in itself is indication for surgery. So collecting all that information would be helpful.
How long do we wait off the HCTZ?
I usually stop it for like 3 to 5 days before I do those tests.
Okay, so fairly quickly then.
Yes,
I'm
yeah,
thinking
it
might
doesn't have to be
weeks,
like,
so, okay, this doesn't have to be a long time.
yep. I think that's all I have. I don't know if anyone else has anything.
Really appreciate that. Yeah, if there are any other questions, or if Dr. Perini, I think she's left on. Yeah, she's still on. Have anything to add? Be happy to.
I mean, how common is this, hyperparathyroid? It seems like sometimes, we go looking and we find, okay, maybe it's not for real. I guess, how much should we be
How com-
chasing? This woman has had, calcium on the high end of normal, slightly elevated now for a few years. Should I have chased it sooner?
So I think anyone with like a high calcium, if it comes back high at any point, or I guess I would say if it's persistently high, like on a couple labs, then I would check sort of a PTH at that point just to see if it's a PTH dependent cause or independent cause. So we see it quite frequently because they're referred to us. So, but yeah, so yeah, anyone with persistent hypercalcemia would definitely check a PTH right at that time to see, because it is I feel like more common than there's probably patients we're missing out there with, hyperparathyroidism for a while. Again, you want to look at like, could any of their medications be contributing to the calcium? So that's another thing to look at too.
Well, thanks. This gives us some things to go on here anyway.
Yep.
Absolutely. Thank you so much. Any other questions, Dr. Rexroad?
I think that's got it. I'm waiting for your recommendations. I can make an action plan here.
We'll get those to you for sure. Mitra gets them down, I'll send them to you. Other than that, really do appreciate the case. If there aren't any other questions, I just have one single announcement. Our next time that we're going to be tentatively meeting just depends on our meeting. We're having our annual meeting, so it just depends on the agenda, but we are set to meet on the 24th discussing obesity with Maywish Martin.
And I was just going to add to Maywish Martin is part of the occupational medicine residency group, and we're doing collaboration with them. So making sure we have support for that resident. It'll be her first time presenting. It'll be awesome if we can all hop on and support her in that sense as well. So we're excited about that. And her director and all those folks will be on as well. So it'll be kind of cool to see our group and their group come together, and we can do some great collaboration.
Absolutely. Thank you so much, Mitra. And thank you, everyone. I hope you have a wonderful evening.
Thanks, everyone.
Thank you.